Hi, I'm Anas Atullah, and I practice at Fira Podiatry Associates in Trenton, Michigan. Today, I will be discussing how metatarsus adductus affects HAV correction. We'll be going through a little introduction. We'll discuss some things to consider during your preoperative evaluation, of course, procedure selection, and then we'll have a little summary. So, as we all know, metatarsus adductus is a congenital foot deformity characterized by forefoot adduction in relation to the rear foot at the less frank joint. The prevalence of metatarsus in patients with hallux valgus is approximately 35%. Hallux valgus in the presence of metatarsus adductus complicates surgical correction because you're going to need to consider possibly correcting for the metatarsus adductus as well. There is an increased rate of recurrence in HAV with metatarsus adductus if left untreated in the moderate and severe cases. So, things to consider during your preoperative evaluation. The clinical presentation is usually a lot worse than what the radiographs show. You want to consider the severity of the HAV deformity itself. The radiograph here on the right is showing you Engel's angle, which is the normal is about under 25 degrees, and the radiograph on the left is showing you the metaductus angle, and the normal is about 15 degrees. So in these cases, your true intermetatarsal angle is the intermetatarsal angle plus the total of the metatarsus adductus angle minus 15. How many of the lesser metatarsals are involved is another thing that you want to consider. And does the patient have first MPJ arthritis? And then, of course, patient selection, you want to take their age, comorbidities, activity levels, and so on and so forth into consideration. And of note, the metatarsus adductus angle here is the bisection of the longitudinal axis of the lesser tarsus as well as the longitudinal axis of the second metatarsal. So for procedure selection in regards to correcting the HAV deformity, distal procedures are appropriate for the mild and moderate HAV with a mild metatarsus adductus. Anything for moderate to severe HAV with moderate to severe metatarsus adductus result in poor outcomes. There is a much higher rate of recurrence. And in patients with a significant adaptation of the distal cartilage of the first metatarsal, aka abnormal pasa, you want to consider a revertant type osteotomy as well as a more proximal metaphyseal based osteotomy. For the moderate to severe HAV, of course, you want to consider a more proximal procedure. The most common ones in cases with metaductus include a lapidus, closing base wedge osteotomy, and a opening base wedge osteotomy. In these cases, a slight overcorrection of the IM angle is not a bad idea. The chances of you actually developing hallux varus is much less in these cases. And if you're considering doing an Aiken osteotomy, keep in mind that the gapping between the hallux and the second toe is going to be pretty significant because the lesser digits are already abducted in these cases. So that's something you want to discuss with your patient beforehand as well, just to set their expectations straight. So in this picture here, it's showing a opening base wedge in the medial cuneiform. If the medial angulation of the distal aspect of the medial cuneiform is the principal deformity, then an open wedge cuneiform osteotomy is appropriate. And if this osteotomy is made at the midpoint of the cuneiform, as depicted in this picture, the osteotomy may be deepened through the second cuneiform without any harm to the base of the second metatarsal. If the deformity is fixed and the foot is rigid, it may not be possible to gain adequate correction by cuneiform osteotomy alone, and so an additional correction may be gained by removing a wedge of bone from the cuboid. And if you do end up doing that, then you want to orient the apex of the cut toward the medial cuneiform cut, again, as it shows here in this picture. For the arthritic first MPJ, the procedure of choice here is first MPJ fusion, given the right patient, of course. There's a high success rate with this procedure and a much less rate of recurrence. So switching now to procedure selection for the Metatarsus deformity. A mild metatarsus adductus in the adult patient is frequently left untreated, and that's fine. However, in the moderate to severe cases, you definitely want to consider a lesser metatarsal osteotomy. Your options here, either a lateral closing base wedge osteotomy or a more distal oblique osteotomy to lateralize the lesser metatarsal, or metatarsals if you do 2 and 3. In the more severe deformities, a pen met head resection is not a bad idea, something to consider as well, but you do risk shortening and malposition in the sagittal plane. Other procedure selections include second and third TMTJ fusion. If there is a pes planus foot deformity as well, you want to consider correcting that as well. However, take caution because there are certain procedures such as Kidner or Evans that if you're too aggressive, you can exaggerate the metatarsus deformity. To summarize, HAV correction in the presence of metatarsus does make procedure selection much more challenging. Correction of the HAV deformity alone has high success only in the mild metatarsus adductus. If untreated in the moderate to severe metatarsus, the correction of HAV alone can result in residual HAV deformity as well as a much higher recurrence rate. And these are my references. I would like to thank you for giving me the opportunity to present at the MPMA conference. Please do not hesitate if you have any questions to reach out, and I look forward to meeting you all over the weekend. Thank you.